which is on the relationship between alcohol and cancer. So Beatrice, myself, and Dr. Daniela Mariosa will be kind of sharing this presentation. So please, Beatrice, over to you.
Can you see my screen?
Yep.
Thank you. Okay, so our presentation, the first part of this presentation on alcohol and cancer will be split into 3 parts. First, cancer sites and mechanisms by myself, then the global attributable burden by my colleague Harriet Bromgay, and then a presentation on alcohol reduction or cessation by my colleague Daniela Mariosa. So the carcinogenicity of alcohol has been known since long. In fact, the first IAC monograph to establish that alcohol causes cancer to human and is classified as group 1 carcinogen dates from 1987. And interestingly, this was only shortly after the carcinogenicity of tobacco alcohol has been established, yet the way to prevent cancer caused by alcohol is much further beyond that for tobacco. Further updates of the monographs were done in 2010 and in 2012. And together with the evaluation of alcoholic beverages, the monograph programs also evaluated ethanol, which is the main component of alcoholic beverages, as a group 1 carcinogen, and also the acetaldehyde, which is associated with the consumption of alcoholic beverage, the first metabolite of alcohol when alcohol enters the body, is also a group 1 agent carcinogenic to human. So alcohol causes cancers at multiple sites, as you saw on the quiz. Some of them with sufficient evidence for the oral cavity, the pharynx, the larynx, esophagus, cancer of the breast, of the liver, and of the colorectal. All these cancers can be related to alcohol. The evidence for the pancreas at the time of the last monograph was still limited, but I think there's plenty of more recent evidence, and maybe today it would also appear as having sufficient evidence. Interestingly, there are a couple of sites for which it was shown that there's evidence suggesting lack of carcinogenicity for non-Hodgkin lymphoma and for the kidney. But I think the left part of the screen is much more important to bear in mind in terms of public health. So one of the key messages I want to come across is that even small amounts of alcohol can increase the risk of cancer. And you can see for breast cancer, from the very first sip, you have an increase in the risk, which is very linear up to very high doses. In fact, for a number of cancers, the risk increases from the first drink. For a couple of others, like colorectal and for the liver, it's more for the heavier drinking that the risk starts to increase. But I think as soon as you have certain sites for which the risk increases from the beginning, this is strong enough a message to remember. Another important point is the synergy between alcohol and tobacco. They often go together, and the risk of cancer is multiplicative, that means greater than additive, for the cancers of the head and neck, for both men and for women, for all ages and in all regions of the world. So if you smoke and drink, your risk increases much more than for each of them separately. What are the mechanisms that through which alcohol causes cancer? Were there actually 4 of them? One of them I've already mentioned. Alcohol breaks down in acetaldehyde, and acetaldehyde is mutagenic and causes DNA damage. Another mechanism is through oxidative stress, which increases the risk of cancer by damaging DNA protein cells and increasing inflammation. Another mechanism is through hormones, where alcohol alters the level of the multiple hormones and then dysregulates the hormonal metabolites in the body, and thus increasing cancer, namely, for example, for breast cancer. The last one relates to the synergy between tobacco and alcohol, and where alcohol actually increases the absorption of many carcinogens. Another important point is that the risk of alcohol-related cancer is increased in some population that lack certain enzymes that can metabolize alcohol to acetaldehyde or acetaldehyde to further metabolism. So this is typically seen in some Asian populations with some of whom cannot drink at all because of very strong reactions to alcohol. And if those people drink, then the risk of cancer is much higher than for people carrying the common allele. Okay, so much for this part, and I'll hand over to Harriet to talk about the global attributable burden.
Thank you, Beatrice. Maybe I'll share my slides and then
Sure.
I
Yeah.
have some animations that might be a bit annoying for you to have to click through. Okay, so please let me know that you can see my slides okay. It should be fine.
Yes, all good.
Yeah, great. Thank you. Yeah, so I will go through. Oh no, sorry, this started at the start of the presentation. So I'll go over the global burden of cancer that is due to drinking alcohol. Oh, I think I stopped sharing again. Sorry about that. Here we go. Sorry about that. Okay, so when we're working on these estimates to try and come up with the number or the proportion of the global burden of cancer that is due to drinking alcohol, we try and calculate this by coming with an approach to estimate how many cases of cancer could be avoided if no one in the population drank alcohol. So we do this using three types of information. So firstly, the amount of alcohol that people drink in the population. Secondly, the amount that drinking alcohol increases the risk of cancer. So there's cancers that are linked to drinking alcohol. And then finally, the number of people in the population that are diagnosed with cancer. And so we triangulate these three types of information or these three data sources to come up with the estimate of how many cases of cancer are attributable to drinking alcohol. So we have worked on a global study, which we published a few years ago, and we found that globally, around 4% of cancers diagnosed in 2020 were attributable to drinking alcohol. So that was around 1 in 25 cancer cases. And that was 741,000 people diagnosed with cancer in 2020 that was due to drinking alcohol. The majority of these cases are among men. So around 569,000 men were diagnosed with the cancer due to drinking alcohol in 2020, and then the remainder was among women. And when we look at the cancer types that were contributing these cases attributable to drinking alcohol, we find that esophageal cancer contributes around a quarter of those cases due to drinking alcohol. Followed by liver cancer, which contributes around a fifth of cancer cases due to drinking alcohol. And then breast cancer, which, as Beatrice mentioned, is one of the cancer types linked to drinking alcohol, but the amount that the risk of breast cancer increases with one alcoholic drink per day, for example, is quite low compared to some of the other cancer types. But when we see at the population level, the number of cases due to drinking alcohol, this is one of the major cancer types that is contributing to those cases. This is something that we've highlighted in some previous communications with the WHO, especially the Regional Office for Europe, highlighting that this breast cancer burden due to drinking alcohol, this is coming from even drinking one alcoholic drink per day, and this is the most common type of cancer associated with drinking alcohol among women at the global level. So if we look at the proportion of cancer cases due to drinking alcohol in different countries across the world, we find that the largest proportion of cancer cases due to drinking alcohol is found in Eastern European countries and Eastern Asian countries. And this is due to kind of the higher rates of drinking and at higher levels than other parts of the world. And then especially in Eastern Asia, there's a higher burden of liver and esophageal cancers, which when combined with the alcohol drinking in those countries, this is bringing up the burden of cancer due to drinking alcohol compared to other regions. And then you can see in the lighter blue colors, those regions such as Northern Africa and Western Asia, where the lowest proportions of cancer due to drinking alcohol exist. And this is also where the lowest levels of drinking alcohol are in the world. And then finally, I wanted to highlight some of the work that we did where looking at the global burden of cancer due to drinking alcohol, we could then split this by 3 levels of intake. So showing that the heavy drinking, so this is 6 standard alcoholic drinks per day. This contributed nearly half of the number of cancer cases due to drinking alcohol. But then the other 2 levels of drinking. So we have this risky drinking category, which is between 2 and 6 standard alcoholic drinks per day, and moderate drinking, which was up to 2 alcoholic drinks per day. These other 2 categories contribute more than half of the burden of cancers due to drinking alcohol, and especially the lower drinking level, so this moderate category, this contributed around 100,000 cases of cancer in 2020. So also highlighting that even at lower levels of drinking, this can really contribute to the number of cases of cancer due to drinking alcohol. So just to summarize quickly what I just went through, alcohol drinking causes around 4% of cancer cases globally per year. And this was around 740,000 cases in 2020. Esophageal cancer, liver cancer, and breast cancer are the major cancer types when we think about the number of attributable cases. And also highlighting here that breast cancer is one of those where we see a lower risk associated with drinking, but that really contributes a lot of attributable cases at the population level. And again, just highlighting here that lower drinking levels can significantly contribute to the burden of cancer due to alcohol. So I will finish there and hand over to Dr. Daniela Mariosa, who will go over the evidence on alcohol reduction or cessation and cancer risk. Daniela, did you want to share your slides?
Yes, thanks, Harriet.
Yeah,
I will
great.
do it now.
I'll stop sharing.
Let me see. Okay. Seems. Do you see the correct display? Perfect. Yeah. So yes, you were saying I will introduce today the evidence that reduction or cessation of alcohol consumption affect cancer risk. And to that end, I will start introducing 2 flagship projects at IARC, the IARC Monograph Program and the IARC Handbooks Program. The IARC Monograph Programs identifies and evaluates the preventable causes of cancers in humans, such as chemicals, occupational exposures, biological agents, or lifestyle factors, while the IARC Handbooks are the corresponding publication that focus on the evaluation of cancer preventive potential of agents and interventions. And there are 2 two types of intervention that are considered: primary prevention, like chemoprevention or personal actions, and then secondary prevention intervention. And as part of the work, of the handbook's work in primary prevention, an IARC handbook on alcohol prevention is in preparation, volume 20. And this work follow the same framework as the series of IARC handbooks on tobacco prevention, when there was a first volume that focused on quitting smoking. And then the following 3 volumes were focusing on intervention that don't directly affect cancer risk, but affect cancer risk through the intermediate of quitting smoking. So these 3 volumes are on policies for reducing tobacco smoking. So in the context of the alcohol handbooks, the first step then is the review of the evidence for reversal of risk with the reduction or cessation of alcohol consumption. And this work is carried out in the IARC handbooks volume 20A, reduction or cessation of alcoholic beverage consumption. While the second part of the work is IARC handbook volume 20B, this is on alcohol policies, and this volume will be fully published in October 2025, and Doug will tell you more about this work. But for now, let's focus on volume 20A. Is the review of the evidence then on reduction or cessation of alcoholic beverage in relation to cancer risk, which focus on seven cancer sites for which alcohol consumption is the risk factor, and review both epidemiological studies and mechanistic data. So the work has been carried out in collaboration of the IARC Secretariat and a working group of 15 experts from all over the world that reviewed and summarized the relevant studies, and then evaluated the evidence during the meeting that was held in May 2023 in Lyon. And to reach in evaluation, the IARC handbooks follow a rigorous process that start with the systematic reviews of the eligible studies, and the type of study included are diverse. So there are experimental studies, observational studies, and combined analysis. And then each study that is eligible is included regardless of the quality, but the quality is thoroughly assessed to then identify how informative is each study. And then the whole body of literature is considered for the evaluation. That is based on the consistency between studies and also on the reason for the inconsistencies. So while inconsistencies result in low quality studies, may be less of a concern than inconsistency in results for high quality studies. So for the epidemiological studies that have been reviewed for Handbook 20A, overall, throughout the different cancer sites, we could see there were less number of studies identified for reducing alcohol consumption and for the time since alcohol drinking cessation, so the first 2 columns in the table, compared to the alcohol drinking cessation that is presented in the third table. And the main challenges that have been faced by the working group is that most studies presented relative risk for current and former drinking using never drinking as the reference category. So in that case, the working group recalculated all the relative risk for former drinking versus current drinking, because this is answering the question of interest for the handbook. So the second challenge was that the multiplicative interaction with tobacco smoking posed concern of residual confounding when information of tobacco smoking was not included properly in the study. And then the third challenge was that for several organ sites, like breast and colon, there was only small increases in risk or only with heavy drinking. So this was harder to evaluate compared to other studies, cancer sites. So the second line of evidence that was considered together with epidemiological studies is the mechanistic data. So here, to start with, we can identify that there are several biological mechanisms that are involved in the alcohol-induced carcinogenesis. And the working group then identified the studies of biomarkers that are on the pathways for alcohol-related cancerogenesis. And for the evaluations now, the evaluation of the epidemiological studies showed that there was sufficient evidence for cancers of the oral cavity and the esophagus. And this means that is the highest level of the of evidence that we can classify the cancer types in. So there's alcohol reduction or cessation compared to continued consumption reduce alcohol-related risk for these cancer types. While for the other 5 cancer types, they were categorized in lower level of evidence. So their effect of alcohol reduction or cessation for this cancer type was less clear. And for the evaluation of the mechanistic data, there was also sufficient evidence of the effect of cessation of alcohol on carcinogenic mechanisms. And the strong evidence was for 3 mechanisms. The first one was the decreasing of acetaldehyde levels, then reversing the damage in the intestine and the microbiome. And the third one is reducing DNA damage. The working group also highlighted some scientific gaps for some or all of the alcohol-related cancers. So there was not sufficient evidence on the duration of cessation necessary to observe a reduced risk. On the reduction in consumptions, on the amount of the reduction in consumption, on the patterns of consumption over life course, and the risk of molecular or anatomical subtypes of cancer specifically, and on the biological mechanism that mediate the variation in the association for duration of cessation specifically. But to conclude this part, the main take-home message is like, yes, compared with continued consumption, the working group has been identifying that alcohol reduction or cessation is established to prevent cancer on the oral cavity and esophagus. And with this, back to you.
Thank you very much, Daniela, for this very excellent summary of the evidence from the most recent IARC Handbook 20A on alcohol reduction and cessation. Now we'll turn our attention to the influence of the alcohol industry. And I here want to welcome Dr. Karine Galopel-Morvan, who is a professor in social marketing at the École des Hautes Études en Santé Publique. I should know that better. School of Advanced Studies in Public Health, and she's working in Rennes in France. Karine, the floor is yours.
Thank you very much, Beatrice. And can you see my screen?
Yes, very much.
Okay.
Very well.
So thank you, first of all, thank you for your invitation. I'm delighted to join you today. I'm really sorry, but we have to leave you at 2, so I cannot attend the full conference. So yes, Harriet asked me some weeks ago to speak about the influence of the alcohol industry. And I would like to make a focus on one case study that we are working on at the moment in my school, in my research lab. It's about alcohol warnings and how the alcohol industry tries to influence and to stop the implementation and the development of alcohol warnings in the world. Just a few words on who I am and the different research we conduct. So I work on social marketing, for instance, how to improve the effectiveness of alcohol warnings, which is one topic on alcohol marketing, and also on what we called before critical social marketing, which is called now commercial determinants of health. And so we analyze how the lobbying of the tobacco and the alcohol industry stops the development or the implementation of effective prevention tools, for instance, like alcohol warnings. So I will go very fast on these figures because I'm sure that you mentioned it before. So you all know that there are a lot of people who die because of alcohol consumption in the world due to cancers and so on. And so in order to prevent this damage, different action plans are recommended by public health actors, including this one proposed by the WHO some years ago. And in order to prevent from alcohol problems, for instance, the Article 8 of this report, one recommendation is to display information for health protection on alcohol content in a way that is understood by consumers. It's what we call health warnings or labels, alcohol labels, and so on. So it's really a strong recommendation made by the WHO, but also by other public health actors that recommend mandatory and not optional, but mandatory health warnings. For instance, well, of course, WHO, but also NGOs like Eurocare and so on. Almost all public health actors involved in that question, they recommend the mandatory health warnings on the alcohol containers. It was also the case of Europe's Beating Cancer Plan in 2021 that suggested a mandatory indication of different information, including the list of ingredients and nutrition declaration of alcohol beverages, and also health warnings on labels. Today, so before the end of 2023, for the moment, it was not implemented in Europe. We'll see why in the next slides. And so why these alcohol warnings are recommended by public health actors? It's because now they are evidence-based. There are quite a lot of papers that have been published in the last decades, less than tobacco warnings, but I think we're at about 80 papers now that clearly highlight that it is an effective preventive tool, a very effective measure. So we know it's interesting and relevant to inform and to change beliefs about alcohol among people. What we know too, based on the scientific literature, is that it is an effective population level strategy and to display alcohol warnings on alcohol bottles and containers because it increases knowledge and awareness of harms on drinking guidelines proposed by some countries. It has an impact on beliefs, attitude, and images of alcohol, and it also can influence behaviors. For instance, quitting during pregnancy or driving and stop drinking while people drive. But there are some conditions, and it works if warnings are sufficiently visible on the containers. It works if these warnings are easy to understand and if they are clear for consumers. If the content is credible, of course. If it's large enough, I would say, to break the marketing efforts of the alcohol industry on the packaging of the bottles. I think that in many countries in the world, the alcohol industry is very clever and smart to think of very creative and attractive packaging for the alcohol bottles that can attract very young people. So if warnings are quite large and red and so on. So it can break this marketing on packaging. Warnings are also effective if they are rotated. If you put the same, like in France, for instance, if you put the same warning for 30 or 40 years, well, people will get used of it and they won't pay attention to warnings anymore. It's important to use different warnings that could target different people, young people, women, men, and so on. And in order to target people who are not very comfortable with reading text, it is recommended to combine text with pictograms or photos. And of course, it's very important that these warnings are mandatory and not optional for the alcohol industry, and chosen by public health actors and not chosen by alcohol industry. And it's important to also to mention that if you consider mass media campaigns, for instance, to warn people about alcohol harms, it costs a lot for governments. It's very, very expensive. But regarding warnings, it's free for government. So it's important, especially at this time, to keep that in mind. So I sum up very briefly the evidence, scientific evidence on alcohol warnings. But however, if we consider the current situation in the world, it's quite worrying to see that most warning display on containers and also in some countries on alcohol arts are not evidence-based and are not mandatory. Here are some examples, like in the US, they are text only, and in many ads that you can see in ads that you can see on the screen, warnings are displayed are very small, first of all, and they are displayed at the bottom of the ad, and they are not very visible. And a report wrote by the WHO Europe highlighted that in 2025, only 13 out of the 52 member states of this region, European region, had mandatory health warnings on alcohol labels. So it's to very, very small number of countries where, and however, we have this scientific evidence. So why? How to explain the current situation, considering that we know that warnings are effective, and at the same time there are very few countries that had adopted it in a good, in appropriate content and format and mandatory. So one reason is a very strong lobbying of the alcohol industry. When effective warnings are planned and discussed in a country, there are two countries that we can show as examples. Ireland, for instance, it is planned to implement the warnings you can see on the screen with two large messages on the question of cancers and on other diseases. But there was a very, very strong lobbying of the alcohol industry, and still at the moment, in the last month, the alcohol industry tried to delay the implementation of this effective warning. So we don't know if they will be really implemented in 2026 because there is a big battle at the moment between public health actors and the alcohol industry. And it was the same in Australia that implemented in 2023 these warnings on pregnancy consumption, and it has taken around 7 years of lobbying against the alcohol industry to implement and to get the law to get mandatory warnings on pregnancy problems. So that's why we decided to work on this question of the lobbying of the alcohol industry against this measure in my research lab, and there are quite there are too little research on that question in the world, unfortunately. However, it's very crucial to analyze and resist the lobbying of the alcohol industry against these measures, but also other effective measures on alcohol control. So we did, well, I won't get into details. I show you the papers that were published, so you can get the paper if you want more details on that. But we conducted a research in France. The current situation in France is that on bottles we have a very small warnings on the pregnancy, like you can see on the screen. It's a very, very small and not very visible. So it was implemented in 2007, sorry, and it was recommended by public health actors in 2018 to enlarge this warning, which is not very visible at all. And it never happened. So we decided to analyze different arguments put forward by the alcohol industry against this evolution of the pictogram. And also we also analyze the arguments of the alcohol industry when this small pictogram was discussed and implemented in some decades ago. So we analyzed the media during 20 years, from 2000 to 2020. No, a little bit later than 2020. And so just to show you the main arguments used by the alcohol industry and that we saw in the press, in the media, very strongly spread compared to arguments of public health actors in favor of this measure. First arguments were against the problem that was exaggerated according to the alcohol industry, ineffective, which is not true because there is a strong scientific evidence on that. The alcohol industry also said that the problem is not that high, that big, so it's not necessary to alarm people, to warn people on that because the problem is not as high. This warning, just the little pictogram that could be enlarged, could have also counterproductive effects according to the alcohol industry and the economy, because it will increase the cost on packaging and so on for producers. And the other arguments that we highlighted in the media, in French media, that was that it was better to promote other measures proposed by the alcohol industry, for instance, responsible consumptions, and also important to mention that drinking, wine, for instance, is benefits for health. Better to conduct preventive programs that target pregnant women in the media or very young people, to involve health professionals on that questions, and to collaborate with the alcohol industry in order to find the best way, to set up alcohol warnings. It was exactly the same that was done in research, in some research conducted in Australia and also in Ireland and Canada. A very short presentation on that regarding the question and the situation of the alcohol warnings that was implemented in Australia and New Zealand in 2023, which is interesting according to the scientific evidence because it's large, red, visible, and so on. So there was a very strong lobbying of the alcohol industry with 87 submissions made by this industry. Quite the same than in France, the same sorts of arguments. What is the scientific evidence of the effectiveness of alcohol warnings, potential negative effects on pregnant women, stress, stigma, and so on. it's not fair, according to the alcohol industry, to display a health warning instead of pregnancy warning, because it could penalize the whole population with health warning. So it was better to use pregnancy warning. So it was chosen actually, and the first option, health warning, was not chosen anymore by the government. And another option that fortunately was not chosen by governments was to display drink responsibly instead of pregnancy warning or health warnings. And we absolutely know that it does not work, because it doesn't mean something for people. We tested that in France, for instance. The alcohol industry was also very concerned about the format of this new warning, because of capital letters, size, blah, blah, blah. So actually it was very, very visible, much more visible than the previous one. So it worried a little bit, of course, the alcohol industry. And another argument was the possible negative consequence on the economy, with the argument of unreasonable cost burden on industry, and the benefit of mandatory warnings over voluntary is not proven anymore. So of course the alcohol industry is in favor of voluntary warnings. The last example analyzed by the researchers was the case of alcohol warnings in Canada and Ireland. And the aim of this paper, published in 2020, was to examine the framing of news. Well, we did quite the same than they did, a news coverage on alcohol warnings label initiatives that included a cancer message on alcohol bottles in Canada and Ireland. And this research found out quite very similar arguments opposing warnings compared to what I showed you, to France and Canada, and Australia and New Zealand. So among, for instance, arguments against cancer warnings that was just tested in this paper in these countries at that time. It's not true, or it's not proven to say that alcohol can cause cancer. Warnings are not effective. It can hurt or disadvantage the alcohol industry, cause stigma. It is a disproportionate response. We are the same in France. It will cost a lot for the alcohol industry, etc., etc. I won't get into detail, but there were very similar arguments than the situation in Australia and in France and New Zealand when the new warnings was implemented. So as a take-home message and as a conclusion, I would say that the main problem today with extending alcohol warnings worldwide is not the scientific evidence, for sure. It's really the industry, which adopts international lobbying strategies, the same than with food, same than with tobacco industry, with some local adaptations. For instance, in France, wine growers, because we are the country of wine, were really very, very visible in media, and not, big alcohol companies. Or in some other countries, it will be beer or whiskey, like in Scotland with the minimum unit pricing and so on. So there are local adaptations of very global and lobbying strategies of these big groups. The alcohol industry uses tactics very similar to those used. Well, I've already told that before. To the tobacco industry, I work on that. It was quite the same when the tobacco industry struggled against tobacco warnings and tobacco plain packaging. And so it's crucial to raise awareness of these lobbying strategies arguments, because it's true in France, I don't know in other countries, but in France, public health actors, somewhere they are very naive about that. NGOs, they are very naive about that too. So it's very important to increase the knowledge of these lobbying strategies that are always the same. among public health actors, NGO, journalists, citizens, politicians, and so on. And it is also very important to give NGOs and public health actors advocacy skills, which are sometimes very low, to resist to the alcohol industries lobbying. And it's crucial, of course, to ban alcohol industry companies from engaging in health policy decision, and of course to increase transparency about links between the alcohol industry and MPs or representatives and governments. Thanks a lot for your attention.
Thank you so much, Corinne. Yeah, this was a really insightful deep dive into alcohol warning labels and the tactics that the industry employs when trying to lobby against any alcohol policy suggestions. I'll just remind the audience that Corinne has to leave in the next 5 minutes, so if you have any questions, please do put them in the Q&A. But maybe I can get started. Because Corinne, you mentioned the Yukon study, and I know that the alcohol industry originally they actually put a stop to the study, didn't they?
Yeah.
And so it's not just the delaying; it's also just fully blocking the research and not even letting us create the evidence.
Yeah, thank you for your comment. Because at the moment in Ireland, the alcohol industry tries to delay the implementation that was voted last year. But it's true that in Canada, for instance, the researchers, they conducted research, but exploratory research on cancer messages, which is very, very worrying for the alcohol industry, and to put cancer on these messages. And the alcohol industry stopped. It contacted the government in Canada, and the study, the research had to be stopped.
Yeah, and it was only in a couple of shops where they were running the study, and then the alcohol industry still blocked it completely.
It was a real life study, which was very interesting to analyze what happened in a real context.
Yeah, exactly.
And so, they had to stop the research.
Yeah, and then on your conclusion slide, you mentioned giving NGOs and researchers some tips for advocacy. I wonder if you had any examples that you could share, or just a bit more detail about that.
For instance, I showed you the methods, the analysis that we conducted in France in the press. One recommendation for NGOs or public health sector would be to send arguments in the press too, because it was not very well balanced. And to be honest, on the 20 years that we analyzed, arguments against and for alcohol warnings in France on spectrogram, about 80%, I don't remember exactly the number, but about 80 or 19% was 90%, sorry, was arguments of the alcohol industry, so against as a pictogram. And there were very, very few arguments and messages from NGO. So press release, I think it's very important to do more press release. And also to think of arguments of the alcohol industry, to know the different arguments. It is ineffective, so okay, to answer a journalist and to answer citizens or else. No, it's not true to say it is ineffective because there are different research studies that shows it is an effective measures and so on, among other tools.
Yeah, and I think WHO Europe put together kind of a guidance report for journalists that they shared with journalists to be able to inform them on everything that the alcohol industry is trying to make us believe.
And I think they also published a toolkit on advocacy, not only on warnings, and the same. And I highly recommend it to upload the different toolkit guides and so on of different NGOs. I think it's Tobacco Free Kids. There is a very interesting toolkit on how to conduct advocacy campaigns. It's focused on tobacco, but it's very easy to to use it in alcohol or health. So
yeah, there are
it's
so
really,
many similarities when dealing with these big industries.
they are available in French and in English, of course,
Yeah.
but in French too. So
Yeah, maybe I can find the links to those. Okay, I think you have to leave us now, Corinne, but thank
very
you so
sorry.
much. No
Thank
problem
you
at
for your
all.
invitation. See
Yeah,
you later.
no.
Bye.
Thank you so much. It was a really great
You're
presentation and great to
welcome.
see you as well.
Thank you. Bye.
Okay, so I think we can go to our next presenter today, who is Dr. Dag Regve, who is a senior technical officer at the headquarters of WHO. So are you joining us from Geneva there, Dag? Yeah, if you want to share your slides. And yeah, please take us through your talk on effective policy interventions to reduce alcohol harm. Over to you.
Yeah, thank you very much, Harriet. I hope you see the full screen of my presentation.
Yeah, we can see them well.
Yeah. So thank you very much for the invitation to give a presentation here and try to put what we now have accumulated of knowledge around cancer and alcohol into a broader policy context and see how we can then together take this forward into really reducing alcohol-related harm. And in this process, it's really important to go from myths to measures, because having worked with alcohol prevention now at all levels, from municipality in Norway to the World Health Organization's global headquarters, it's easy to say that there is always reasons for not implementing alcohol control measures. So if you are looking for reasons not to implement alcohol control measures and thus reduce alcohol-related harm, you have so much to take from, to use in what you want to achieve by not reducing alcohol-related harm, because that is, in fact, what you then are doing. So I think it's really important that we now talk about what are the effective measures to reduce alcohol-related harm, what are the global frameworks that we have and guidance that we have, what is now the current state of the evidence, and then how is WHO implementing it, and how can you join in implementing effective measures from your situation, and then together we can work to reduce alcohol-related harms. So first, we need to put alcohol into a context. And that is that, and the industry and many of us don't like to hear that, but ethanol is, which is the main component in alcoholic beverages that we are concerned with, is a psychoactive substance. It has toxic effects on organs and tissues. It's an intoxication which leads to impairment and lack of physical coordination, consciousness, etc., etc. And it also has dependence-producing propensities, where the user loses his or her self-control over the drinking. And it's very interesting, and we don't have time to go, see how the panorama now between tobacco, alcohol, and illicit drugs, how different actors use the different substances to play up against each other and then achieve what they want to achieve. And here is just one example from a campaign to legalize marijuana, and that the main point is that alcohol is less, marijuana is less harmful than alcohol, which we do not agree with. There's different components that creates different types of harms, and this is a much more complicated situation. But we need to keep in mind that. And we also, from a public health perspective, inside the public health perspective, we need to realize that there are three different dimensions that people are also starting their approach to alcohol on. And that is first, and that is the public health stance of WHO, is to focus on what are the negative consequences from the use of the psychoactive substance themselves. So the propensities in the substance. But others like to start with the negative consequences for existing users as well as for the economy and the society at large associated with the control of psychoactive substances, and not say how can you reduce these effects, because they are not neglectable. They are something that you need to address. But if your starting point is there and not the public harm themselves from substances, then we are already on the wrong path. And the third is, of course, not so much with alcohol, but with the other substances, and especially the illicit drugs. The problem is lack of availability of psychoactive substances for medicinal, therapeutic, and scientific purposes. We see this in the cannabis is really one of the leading issues now in the discourse. And paradoxically, here the other day I saw evidence, so-called evidence, about one way of reducing heavy episodic drinking was to let the drinker first have some THC, and if the person then first got THC, it would reduce the heavy episodic drinking and as such reduce the potential for harm. And this see how far out we can take research and science in this area to achieve goals that are not necessarily public health goals in this area. So WHO has clearly stated that when we look at the harmful use of alcohol, that is a very broad concept. It encompasses the drinking that causes the detrimental health and social consequences for the drinker, for the people around the drinker, and for the society at large. But also with patterns of drinking that are associated. So we even don't say that there needs necessarily to be a causal link, but it needs to be clearly associated so we can have a precautionary approach to it with the increased risks of adverse health outcomes. And the reason why I'm stressing this is because some are very interested in creating a difference between harmful use of alcohol and focus on alcohol consumption per se. From us, it is really not a big difference in itself when you look at the definition of harmful use of alcohol. So we have this, so what can we do and what are the entry points for reducing alcohol-related harm and also for psychoactive substances? So here you have the many different pathways that you can enter into. I don't have time to go into detail, but many wants to stay here in these individual factors and try to address the individual factors that creates the harm. Others try to say, oh, it's the culture or it's the level of development. And all these are really interesting and important factors. But from a public health point of view, what we know about the evidence on alcohol-specific measures, because here, remember, we are talking about alcohol-specific measures, is these two brackets here: the prevention, treatment, and harm reduction policies and programs, and the affordability and availability of the substances in the society. And as we have learned from tobacco, if you are successful in promoting this and increasing the control mechanisms, it will have an impact on the culture. And it will reduce the individual risk factors because the population is less exposed to these risk factors. So there's no contradictions around this. But we need to start with what the evidence says about specific alcohol interventions. And just to start, one of the problems we have with alcohol is that it's linked to so many conditions and disorders, much more than tobacco, which is very concentrated. Alcohol is spread out, and even we do not account for all of them. For example, depression is very difficult to get a attributable fraction and estimate the global burden. So depression is, even though we know a very strong association and also causal relation between depression and alcohol, we have difficulties in really estimating. So those are not calculated into this. A lot of the harm to others are not calculated in. So we need also to keep that in mind when we are talking about what is really the level of harms here, because we are saying that we are overestimating the data. I think we can clearly say that based on all the things that are not calculated in, we are not overestimating. And in addition, the so-called beneficial effects are in fact subtracted from this, which means that in de facto, a woman who is living from 80 to 81, that year for her is annulling a kid that dies 15 years of age because of a drink driver. That is what is really happening when we are calculating in the beneficial effects. And that is a huge discussion, which again, I don't have time to go into. So why alcohol policies matters? We heard the reference to the 2.6 million estimated deaths, the leading risk factor for morbidity and mortality among 15 and 49. That is extremely important for the productivity of a society. And that detrimentally linked to around 200 health conditions, as I said. And harm extends beyond the drinker. And here also you see how it's spread around in big disease categories. So it's not in one specific disease category. So that's why we have had a considerable process the last 15 years in WHO and in the UN system to really say that we need to address this from the global level to assist and facilitate action at the national level. the global strategy in 2010, the NCD action plan in 2013 established alcohol as one of the 5 main risk factors for NCDs. Alcohol was included specifically in the target in the SDGs, and we have different reports on the effective measures from the NCD, what is effective. And then we have the Safer Initiative focusing on control measures. I will come back to that. And the Global Alcohol Action Plan, which is really focusing even further on what we really should be working on, because we know it's working. We shouldn't stop developing other interventions and test them and get science around them, but that shouldn't prevent us from implementing what we do in fact know. So I don't have time to go through the SDGs, but alcohol is linked to many of the Sustainable Development Goals. We have the global strategies who says you need to focus on all levels, the level of consumption, the pattern, the context, and the wider social determinants of health. The strategy focus, and this is important because the strategy didn't give any clear directions. It said you need to work in all these 10 areas. They are important. We do not want to give more specific guidance to countries where you should put your work in, but to try to work on all these different areas. Then we got the NCD process who really said, well, what really matters are the most cost-effective interventions, and you should really focus on them first. And that was the availability and the affordability of alcohol, the marketing and drink driving countermeasures, and screening and brief intervention. And then we came to where we are at here in this webinar, and that is then the volume 20B of the Cancer Prevention Handbook of IARC, which followed 20A. It's a little bit opposite order here, but that is because you needed first, as was told, to establish the clear link between the reduction of cessation of alcohol consumption with the incidence of cancer before you could start looking at the interventions and how they, the population-based interventions, and how they reduce alcohol consumption, to build up a clear link between those interventions and this incidence of cancer. Here is the main results of the process. We have talked about the method, and I won't come into that. We have also, the methods will be more clearly described in the handbook itself, but the outcome is most important here. And that is that it clearly established that there is sufficient evidence to work with taxation and minimum pricing. Also, it's important to keep in mind that this process did not establish the cost effectiveness. They were looking only at the effectiveness of the interventions themselves. Availability restrictions, leader purchasing age, total sales bans, strong marketing bans, and coordinated policies. For the first time also we started to get clear evidence around that to have a coordinated approach is really also very effective, and there is sufficient evidence for it. Discount bans did not get support, but that doesn't mean that it might have an effect, but it's really difficult to measure, and especially the way it's implemented and measured makes it difficult. Intuitively, if discount bans reduces all the prices of the alcohol available, it will, through the model that has been developed, reduce alcohol-related harm. But there is something with the implementation and the research which says that currently there is inadequate evidence. It does not mean that it's not really effective if we get new evidence around it. So that is important to highlight. So it's not an evidence of absence of an effect. So implications are the same. These are the measures supporting the NCD action plan and supporting the global action plan on alcohol, that you really, if you want to have a high impact in your country on specific alcohol policy interventions, these are the interventions that you should really focus on. And in this process, there have been some considerations, and I think we need to pause with some of them, especially the first one, that most evidence predates digital marketing and online sales. Before this whole integrated supply chain where you can sit at home and order alcohol and you have it back delivered within an hour, this evidence has not looked into that. And the question to you now is, do you think that will strengthen the evidence for availability reductions or weaken it? The same with digital marketing. this is before the big algorithms, the social media, the targeting, the influencers, and all these things. So the question is, these additions, will that strengthen or weaken the evidence that is already produced? We need to keep in mind that main bulk of the evidence comes from high-income countries, but it is increasing also from low and middle-income countries. And again, it shouldn't prevent you from implementing it, because it's even less evidence for the other interventions. This thing they talked about earlier, you have to look at potential side effects and ethically and human rights and for the economy, but that should then be counted into overall public health approach if you want to do this for public health. If you want to do alcohol taxation for revenues, that's a completely different story. Or if you want to reduce taxation to increase the revenues for the international multinationals, which are now basically owning most of the beer companies around the world, but that's a decision that the government takes. And we just try to provide the evidence for reducing the problems. And proving the public health benefits should remain the focus despite contextual challenges. That is what we're saying all the time. Don't use all baskets of arguments not doing anything that is provided to you from so many different angles. Perhaps even from yourself, if you have a little bit problem that you start shaking with cognitive dissonance because you don't want to be associated with temperance or be an any-state advocate or those things. And finally, the success depends also on a fully policy cycle enactment, implementation, and enforcement, requiring a multi-sectoral, sustainable, long-term approach. And all this is first now summarized in the New England Journal of Medicine article that is just recently published and will come fully in the handbook. I don't have much time to go through the alcohol action plan. I will just looking to SAFER, how we are now trying to implement these effective measures. We are trying to implement it through an initiative that we call SAFER, which are focusing on the 5 most effective and cost-effective interventions. We do it through an organized approach to the SAFER initiative, but basically I'm going to Ireland tomorrow, and there they have taken this by heart, and they are now trying to build SAFER communities. 9 different municipalities in Ireland is now implementing SAFER model to make SAFER communities in Ireland. So there are many different ways of implementing these cost-effective interventions. You need to focus on implementation. We heard about the importance of protection from industry influence. And we also heard about monitoring, how important it is to really monitor what you are doing to strengthen the evidence base for your interventions. So we work in depth with countries to try to implement the interventions. We work with a lot of countries. We had a workshop with 15 countries and a process with 15 countries in Africa now, that we're trying to see how can you go further implement this at the country level. And as I said, through inter-country learning, and we are also trying to see how you can localize SAFER in the municipalities, in the communities. Here is examples from Nepal, where they try to localize SAFER. We have examples from Uganda, in Yincha, how they try to localize SAFER. And here is examples from Ireland, how they try to localize SAFER. Because a lot of the competencies on the effective interventions are, with exemption of pricing, are at the municipal and local levels very often, and at least in a complementary way with national efforts. So I don't know how much time we have, because based on the presentation earlier, I would like to say what kind of safeguard we are now trying to build around a conflict of interest and with the base of what is in the global action plan. Is it 3 minutes, or how much time do I have left?
3 minutes.
3 minutes. So I would like to go through this, just 3 quicks, because many people don't read this in the action plan. But I think it's important for you who are on the ground working on this to understand that all 194 member states of WHO have endorsed and adopted the action plan and these principles and what we call on the industry, how they could contribute to reducing alcohol-related harm. And the action plan says that they should focus on implementation of measures that can contribute to reducing harmful use of alcohol, which are stringently within their core roles as developers, producers, distributors, marketers, and sellers of alcohol beverages. They should abstain from interfering with alcohol policy development. They should refrain from activities that might prevent, delay, or stop the development, enactment, implementation, and enforcement of high-impact strategies and interventions to reduce the harmful use of alcohol. They should take concrete steps towards eliminating the marketing and advertising of alcoholic products to minors. They should refrain from promoting drinking, eliminate and prevent any positive health claims related to alcohol. They should ensure within a regulatory or co-regulatory frameworks, not self-regulation, the availability of easily understood consumer information on the labels of alcohol beverages, including composition, age limits, health warnings, and contradictions for alcohol consumption. They should avoid the circumvention of existing regulations for alcoholic beverages and targeting of new consumers groups with alcohol marketing, advertising, and promotional activities. They should they should contribute to elimination of sales of alcoholic beverages to minors and the elimination of commercial activities targeted towards other high-risk groups. They should refrain from engagement in capacity-building activities outside their core roles that might undermine or compete with the activities of the public health community. They should refrain from funding public health and policy-related activities and research that to prevent any potential bias in agenda setting emerging from the conflict of interest. And they should cease the sponsorship of scientific research on the public health dimensions of alcohol consumption and alcohol policies and its use for marketing and lobbying purposes. And the reason why I'm mentioning this now is because we are seeing, and also through safer intervention and implementation, an increased activity. Some of you might see also this article in Financial Times that they are fearing that they are now in a tobacco momentum. I tell you, they are far from being in a tobacco momentum. There's so many things that needs to be sorted out before we are even there. But there are so many things that are contradicting what public health people are trying to do at the ground in the countries. And that is where we should start now in trying to really fence those clear interventions and prevent them from being sacrificed on the behalf of the industry or other interests in the community. I just want to mention that we have the WHO Forum on Alcohol, Drugs and Addictive Behaviors, where these things and many other things around the psychoactive substances and addictive behaviors like gaming and gambling will be discussed. That is in 24th of 26th of June. It will be online. It is by invitation, but you can approach our webpage and you can register, and we will consider if you are invited or not by that registration, depending on if you have any conflict of interest, which will be strongly assessed before we then send you the invite. So to wrap up, reducing alcohol-related harm requires commitment, engagement, and action. So let's work together to build safer communities free from alcohol-related harm. And reducing harm starts with us, not with anyone else. And only through bold action, strong commitment, and real engagement, we can achieve long-term sustainable changes in society and reduce the suffering that individuals today have to endure because of alcohol consumption in the society. So thank you for your attention.
Thank you very much, Dag. This was really enlightening, a very comprehensive presentation of all the various types of interventions, and really the last 3 slides about how to behave to get things working and to stop influence from the industry. Thank you so much. I'll now hand over to Dr. Mindaugas Stelimekas, who is head of Health Research Institute at the Lithuanian University of Health Science. And Mindaugas will tell us about the great experience in Lithuania. Over to you, Mindaugas.
Thank you very much. I hope you can hear me well and also can see my slides.
Yes.
Right. So first of all, thank you very much for the invitation. I'm very happy to share the Lithuanian experience, and I think we have quite an interesting one. And I think the first 2 presentations, basically all the presentations before mine, covers very well and forms a great background to the experience that Lithuania have, because Lithuania implemented in a relatively short period of time, implemented all the WHO recommended best buys. So all the policies that you described here before, we basically implemented in a relatively tough way. So I'm going to cover those, and basically during the next, well, around 19 minutes, I will go through these 4 main points. And first of all, I will speak a little bit about the background, what I have in mind, a little bit about the policies itself, what we have implemented and what were the results. And specifically, I will want to focus on the aftermath of these policies, because one thing is to implement the policies, another thing is to maintain the policies, because they were, at least in the Lithuanian case, and what I hear from the other country experiences, well, industry is not sleeping. They are actively lobbying against some policies, and we were also experiencing some of very similar, let's say, strategies that were covered here, and I will cover some of those, and of course, I will provide some conclusions. Okay, so what is Lithuania? So we are one of the 3 Baltic countries in northeastern part of Europe. We are a relatively small country of close to 3 million people. And in many indicators, we are approaching the average of the European Union. Of course, we contributed a lot. We got a lot from the ability to join the European Union in 2004. We experienced a tremendous growth of our economy, but also that resulted in some negative side effects. And one in particular was that since around 2000s, we were not implementing no tough or any significant alcohol control policies. And in addition, when we were experiencing a really nice growth of the economy, the income of population was also steadily increasing. So basically that resulted to the decline in alcohol, to the increase of alcohol affordability, and that also increased the alcohol per capita consumption tremendously. Another interesting feature when speaking about Lithuania is that we are, in general, having a life expectancy which differs significantly between men and women, which is here, and we are one of the countries which has one of the biggest gaps in Europe in this area. So actually, men in Lithuania demonstrates a lot of health risky behaviors, and drinking is one of those behaviors, and specifically alcohol control policies targets very nicely into that group of population. So when speaking about Lithuania as a natural experiment in alcohol control, we are first of all having in mind 2 periods. So one of those appeared during the global economic crisis in 2008 and 2009, but we were basically approaching that steadily up till around 2007, because as I already indicated, indicators related to alcohol consumption were steadily going bad up till 2007. And then our civil society was starting to point the many problems related to alcohol, and the policymakers had to react. So basically, alcohol and as a health risk factor and as a political agenda point become an increasingly hot topic in Lithuania, because we had always a very strong lobby from alcohol industry, as well as at around 2008, we also experienced quite a significant development of civil society, and the civil society voice and in terms of NGOs, academia become quite significant. So any discussion on alcohol was always triggering a very wide clash between lobbyists and health advocates, and it was always a very heated discussions developing regarding different questions related to alcohol. Another important period was starting since around 2014 up till 2018, when numerous alcohol policies were implemented, especially the most significant ones, which one of those was the increase of excise taxation since March 2017. Basically, we doubled the excise taxation for beer, wines, and intermediate products, plus a 30% or 20% increase for spirits. And then since 2018, another 3 policies were implemented. A near total ban of alcohol advertising was implemented, including the internet media, etc. Minimum legal drinking age was increased from 18 to 20 years old. And the availability for takeaway alcohol was widened in terms of sale hours. So basically, during the normal weekdays, the alcohol sales for takeaway were allowed from 10 a.m. till 8 p.m. So that was a shrinking by another 4 hours per day. And on Sundays, it was allowed to sell alcohol only from 10 a.m. till 3 p.m. And the argument was that Sunday is not a day to promote drinking. We need to limit the availability of alcohol, because the beginning of the week on Mondays or the afternoons of Sundays need to be sober for quite a significant part of drinkers. And that particular measure was really widely criticized by alcohol industry, and other measures were steadily attacked afterwards. So this is the part where I will concentrate a little bit more. So as I indicated, alcohol was quite a hot topic for many years, and also after 2008, numerous alcohol control policies were implemented in Lithuania. So this is a timeline which we developed in one of our articles some years ago. And specifically, a period starting around 2014 is important, and specifically with several very strong policies. So this is the list basically of all the policies that we managed to identify, but specifically in terms of the degree of the importance of the policies. The policies of 2017 and 2018 were important because, for instance, the increase of excise taxation reduced the alcohol affordability comparing to the previous year. And this is not something that happens very often in a steadily growing economies. Yeah, so this was significant, and that also produced some results. So when looking to the alcohol attributable fraction, we also identified the specific feature related to Lithuania, that Lithuanian males in terms of drinking patterns are closer to the Russian relative risks and Russian drinking traditions. And when speaking about Lithuanian women, well, relative risks from the global epidemiologic studies are fitting much better to define the drinking pattern of women. So basically, when speaking about the alcohol attributable fractions, we could identify that around 15 or above 15% of deaths may be attributed to alcohol in the most recent years for Lithuanian males, and around 5% of deaths may be attributed to women. When speaking about the specific alcohol attributable mortality indicators, so this is one of the general results in analyzing all-cause standardized mortality in Lithuania. So we also identified that in a period when alcohol control policies were implemented, so in 2008 and 2009, and since 2014, the all-cause mortality was declining by 3% more compared to the years when there were no strong alcohol control policies implemented in Lithuania. Also, when looking specifically at the one time point of 2017, when the excise taxation was increased, basically it resulted to over 1,000 deaths averted or postponed within 1 year after policy implementation. So that is quite a lot, and especially when thinking that in Lithuania, annually we have slightly less than 40,000 deaths in total. So that is a significant effect that we managed to show with statistical methods and published the results in showing the effects of alcohol control policies. Now, another important message when thinking about the excise taxation is always the revenues of the excise taxation. So this slide very nicely presents the big shift of and big increase of excise taxation for 2017. And basically that resulted into a win-win situation for Lithuania and specifically for the budget. And that specific case also showed for our policymakers, even for the most liberal ones, that increase or significant increase of excise taxation does not mean that alcohol consumption is shifting to unrecorded consumption. In contrary, it may reduce the per capita consumption, which you can see here as a blue line, which was slightly declining before that and even more declining afterwards. And basically, this is the recorded alcohol consumption that we have. In addition, we analyzed the unrecorded alcohol consumption. I'm not showing the slide here, but unrecorded consumption is not a big challenge in Lithuania, mainly as for the European Union country. We have some problems with unrecorded consumption because of the cross-border shopping. Yeah, because people can freely go to Latvia, can go to Poland, can bring some alcohol, but this is a not widely, spread phenomenon. If people are living near the border, so yeah, they might go there, but usually this is the biggest level of alcohol consumption is the recorded one, and when we implement strong alcohol control policies, so there is a true reduction in alcohol consumption, because we also observe the improvement of public health related indicators as well. And when looking at the revenue, so this is the illustration of excise taxation per capita. So technically in 2016, the total revenue in millions of euros was around 250 million euros, yeah, in 2016. So in 1 year, we increased that figure by over 67 million, up till 317 million, and that was approaching 200 euros per capita. And lastly, in the next few years, there was occasional increase in excise taxation, not a major one, but that also helped us to push alcohol excise taxation by a little bit. And now we can say that it nearly doubled comparing to 2016. Now we have over 290 euros per capita collected from the excise taxation, which is close to €500 million per year. And this is a fantastic news when comparing to the figure which was published in Lithuania just a few days ago. We had a record low of alcohol per capita consumption of 10.2 liters, according to Statistics Lithuania. And in the last several years during the pandemic period, we had some sort of a stagnation period in terms of alcohol consumption. And I think this is a fantastic news that we now have a continuation of decline of alcohol consumption here. So basically, this is a win-win situation. We reduce the alcohol consumption. All the basic economic laws says that it should be that way, and we can also clearly show that it generates revenues and it reduces alcohol consumption because of the law of declining demand when you increase the price of alcohol. Finally, this is another illustration in terms of comparing alcohol consumption and life expectancy. So basically, in Lithuania, we have several such illustrations in showing that when we manage to do something good with alcohol, we have a tremendous increase in our life expectancy. And that's already visible within 1 year when we implement strong alcohol control policies. And this is what you can observe here, especially the major breaking point happened in 2008. Why 2008 was important? Because it was happening in a year after multiple years without any alcohol control policy. So basically it was a low starting point, and it was easy to increase the health indicators, which, as you know, are widely spread related to alcohol across many health indicators, and you can have steady improvements quite quickly. So another part that I'm going to speak here within the next few minutes is some experience what we were dealing afterwards in defending the alcohol control policy. So one of the arguments was that when you increase the alcohol purchase age from 18 to 20 years old, so basically a lot of lobbyists were screaming that basically, could you imagine we are sending our 18-year-olds to serve at the military. They can have a gun, and they are getting back to their pregnant wife, and during the wedding they cannot drink a glass of champagne. Could you imagine such a disaster? So when we deconstructed this situation, so basically it turned out that you basically have just 0.3% of marriages appearing in a very young age. And these are special circumstances only, usually when a wife is pregnant or something. And this is not an argument at all. This is not relevant to young people. And we truly hope that when serving in a military, you are not getting drunk, because you are getting a gun there. And when we started using this argument, that worked very well, and this argument evaporated very quickly. And finally, the Parliament of Lithuania rejected the proposal to reduce again the legal alcohol purchase age. Another important argument that was that during the Sundays we reduced the sale hours, and that was an argument that basically we need to reduce the mortality during the weekends, especially for men. And when we did the analysis for that specific age group during the weekends, we noticed that, and we proved that basically for external causes, after the additional restrictions were implemented on Sundays, the mortality on Sundays went down for external causes. Also on Mondays, we had a reduction of cardiovascular disease mortality, once again for men. And this is the problematic group that we need to tackle with our public health policy. So the policy for Sundays worked fantastically, but what the arguments were used that this is illogical, there is no sense to implement additional restrictions on Sundays, etc. And basically, when we put the arguments, when we put the evidence, so once again, the Parliament voted to reject such a proposal. So To conclude, I just want to say that it is important to have strong alcohol control policies. It is well documented, and if a country has some political will to implement those, this is fantastic. But it is also important not to forget to enforce the policies and to defend the policies. And this is an important role that needs to be performed by the NGOs and academia in the country, as well as together working with the government officials. And finally, when speaking about the government officials, by saying thank you for your attention, I just want to indicate to some champion of Lithuanian alcohol control policy. So this is the ex-minister Aurelijus Veryga, who was a former researcher. Actually, he was working in this specific office, and he was my PhD supervisor who went to become a politician, and he was, holding the flag of alcohol control policies, and his opponents were portraying him as a radical, as a Taliban, etc. And basically, he became very well known because of his strong alcohol control policies, which turned out to be working very well. So thank you very much for your attention, and apologies for taking over for additional 1 minute.
Thank you so much, Mindaugas. It's also always very incredible to hear the success story of Lithuania, and also very important to understand that, yeah, once the policy is implemented, you still need to keep fighting. But it really seems that you really have this under extreme good control, and congratulations to your country. Okay, so we have now ended up all our presentation, and we'll open the floor to Q&A session. So please free to ask all the questions to the panelists who are still on the call, and Harriet and myself will moderate the questions. There may already be some in the chat right now.
Yeah, there was a few questions in the Q&A which I thought could be nice to bring up for discussion. I know, Dag, you already typed some responses, but I just wondered if you wanted to share some of your thoughts and the WHO's kind of approach to low and no alcoholic beverages, and what you would advise on this, whether that is a prevention strategy or yeah, what would you think?
Thank you very much, Harriet. And I've seen from the questions also, and we know from the field that this is a very contested area because it involves actions from the industry, and many don't really believe that the intentions of the industry are good-hearted. We have a different approach in WHO. We try to look at what different stakeholders can contribute to in good faith with reducing alcohol-related harm. And one of the issues that have popped up constantly is, and both from modeling and from intuitive understanding, to reduce the content of alcohol beverages inside each category. So if you reduce a vodka bottle from 44 to 40%, not for tax purposes, but they do in many countries, but to reduce the exposure to the population, is the same with wine. The wine has gone the other way, because of the climate change. And for beer also, especially with all the craft beer, it's gone the different way. But if you can reduce the alcohol volume content in each of these categories, it intuitively makes sense. At the same time, if you afford non-alcoholic beverages into high prevalent settings, which at the same time make them possible not to be excluded from the setting, or taking a pause in the drinking, not to be seen as then not being part of the group, all this makes intuitive sense. And that's why we have said that this is a potential area for development, but we need much more evidence. Unfortunately, what we have seen from the implementation of this measure is that it's used as a way to circumvent alcohol laws, especially marketing laws. We have also seen how it has been used as an attempt to introduce because we still believe that even though it's non-alcoholic beer or wine and even spirits are now available in non-alcoholic formats, it is still part of the alcohol culture. And I think that is what we should really fence around. That it's still part of the alcohol culture. So it makes sense inside an alcohol culture. It does not make sense outside of an alcohol culture. I think that's the first boundary that we should make. And secondly, when we see now how they just use the same logos and put 0.0 or even 0 or any kind to say that, oh no, this is not an alcoholic beverage. Well, what you see is the brand of a mark of an alcoholic beverage, and then suddenly they can sponsor big sporting events and be part of Formula One or the Olympics, because now it's non-alcoholic. We are much more skeptical to that. So that is a way of marketing alcohol, which also the action plan clearly says that this should be avoided. And then also it can, of course, work as an introductory drink. So I must admit that it's a challenge whether you, for example, should drink a non-alcoholic beer in the presence of your children if you want them to not be exposed to alcohol culture. That is a huge dilemma, because with all this focus we now have on sugar content beverages, and that we should try to phase that out of our culture with high sugar content drinks. The alternatives, if you want to drink, is not very high. So this is also, and non-alcoholic beverages can, because now they also contain no sugar, for example. The latest versions of beer, non-alcoholic beer, have no sugar. So this is a very, very complicated picture. We don't want to say that, no, stop doing it. We think that intuitively and by modeling it makes sense, but we also see how this potentially can and is misused for marketing of alcohol beverages, and can be an introduction to alcohol in non-alcohol cultures. So there are many caveats here, and we need much more research before we can really reach a conclusion, but we don't think it's at the right stage now to just throw it out as a potential additional intervention.
Thank you, Dag. This really raises all the important points about alcoholic beverages and the dilemma between choosing and not choosing, and a little bit similar to the e-cigarettes, avoiding initiation, and it's not always used for stopping, and so on and so on. So I don't see any other question in the Q&A. I would have a question for Mindaugas. On the panel, we probably have many people who would be interested in implementing some sort of action in their country. So, should do all at once? Should we do little by little, see which one works in a country specific setting? Or what would be, in a few words, what would be your recommendations?
I think it's a very country specific, and you should look for windows of opportunity, as a politician would say. And if you have a window of opportunity, in Lithuanian case, it was the beginning of a term for the new parliament, when a lot of new members of parliament were elected, and then they implemented all at once. But that was, let's say, a great window of opportunity that we had. And it would be fantastic to have all in one period of one time point. Then it would be very convenient for researchers to evaluate the effects. But also when it comes to the taxation, so even the constant increase of alcohol taxation is also a great win. The important thing is to bring and spread the message that alcohol control policies do work. And when the politicians do not have a stomach for one policy or another, they perhaps might be eager to implement some of those, like, for instance, alcohol taxation. We are living in times when the budget constraints are quite huge. And this is one of the source of budget revenues, which is a fantastic one, and generates a win-win situation for a country.
Great, thank you.
I saw there was another question in the Q&A about the high-level meeting, and maybe Dag would be able to answer this. If you're aware of any industry attempts to interfere ahead of the high-level meeting, and what activities or arguments are you aware of? I'm assuming maybe some around talking about the harmful use of alcohol rather than the use of alcohol. But yeah, Dag, if you have any thoughts?
Well, of course, I have to be careful to say anything around what is going on now. What I can say is that this is now in the hands of the member states of the UN, and this is the UN. It's not WHO. So it's part of the UN General Assembly, which is more or less the same member states with some few additions, perhaps even more additions in the future. Anyhow, let's not go into that discussion. But so this is a UN process, but it has gone in parallel. And of course, WHO is strongly involved in this. And this started with a political declaration and been several different declarations. So this is the fourth political declaration reinforcing the NCD action plan and taking it up, just like with the SDGs, taking it up to a higher level, not only in a specialized agency on health like WHO, but in the whole UN family. So that's why this is an extremely important process. It has much broader outreach than through WHO and WHO member states. So that's why this is an extremely important process to add value to reducing alcohol-related harm, as alcohol is one of the 5 risk factors. Of course, there are several controversies in that, and there have been strong statements. So this thing that eliminating marketing towards children was taken in the 2017 declaration. So there are, but at the same time, the industry through ECOSOC has more direct impasse into the deliberations in the UN system than, for example, what they have in WHO. So there's more scope for them to formally influence the process. And of course, also through other channels. But again, the point is that this is now currently, well, at the hands of the member states. There were ending of a consultation on a 0 draft earlier last week. And now it will be all up to the deliberations towards the UN and during the UN high-level meeting. And of course, alcohol, we know that alcohol is one of the most contested areas there, and there will be strong pull and push in all different directions. And that's why it's important to mobilize the public health community and to understand the importance, because it can be difficult to understand why this process far away, high up, with a couple of sentences here and there, why it is important. But I'll tell you, and please listen to me, this is important. So that's why it's important that the public health community mobilize to get the best outcome of that declaration, so it can reinforce the path that we already have through the strategy and the action plan and the SAFER, to really focus on what we know are the most effective interventions, because that is what this fight is all about. It's not about whether it should be harmful use or alcohol or consumption or harmful use of alcohol. These are just kind of flavors around, which for some people and for some processes are very important. Language formulates thinking and then formulates actions. So that's why language is important. But I say these are not the main issues. The main issues is to hedge around the most cost-effective interventions to reduce alcohol-related harm. That has been our focus all the time. Thank you.
Yeah, and I think that also kind of, well, I think that partly answers Martin's question in the Q&A. Before we can even think about an end game for alcohol, there are cost-effective policies that are not being implemented, as if like to the best level possible in many countries. And so we need to still promote those policies before we think about an end game, because you know how the public thinks about drinking alcohol, how acceptable it is socially, and so this would still need to change before getting onto a kind of alcohol end game, as we've seen for tobacco. if
If
you
I
have
can
any
just,
reflections as well, Dag.
Yes. First of all, I don't like the use of the word end game, because that is not where we are at now, because we are at a completely different level, and have these idealistic motives or aims is of course good to stretch towards. We had the issue with the road traffic, we had the zero vision in road traffic and those things. So I think it's what the end game should be about is to end alcohol-related harms. And that should be the end game. And of course, if to get rid of alcohol from the surface of the earth is the best way to reach that goal, okay, we can take a discussion around that. But again, back to, if you want change at a global level, we need change at the national level first, because it's the member states of WHO and it's the member states of the UN who in the end decides on where the world as such is going forward. So that's why UN and WHO are important, but we are not more important than each individual member states. Those are the most important level to work on, and on the subnational level, because if you are not creating an understanding there and a need there for effective alcohol policies, there's not, WHO Secretariat, we can only do whatever the member states tell us to do. So there is where the change need to happen. So if you want to build a momentum, for example, towards the Framework Convention on Alcohol Control that many want, well, that cannot be done without the member states agreeing to do that. That cannot be decided by the WHO Secretariat. And this understanding of these dynamics and how important, and you're not using WHO for an end game, but saying that we need to have a country who really focuses on reducing alcohol-related harm and really are dedicated long-term to do it. And then we build up from there. That's where we are at currently with alcohol. We are not even close to anything that we call an end game or a framework convention of alcohol control, because there's no political consensus around it, especially in the geopolitical situation we have now. So country level, working with people, working with yourself, and saying to yourself, why is it important for us to work on alcohol and support effective interventions locally and nationally? That's the way to go.
Thank you so much. And I think we have reached the hour, and we have reached the time to conclude this very, very exciting seminar. So big thank you to all our speakers for this presentation. And based on what has been presented, I think we can say that the following take-home messages would be that alcohol causes cancer at 7 different organs, and 4% of all cases of cancer in the world are due to alcohol each year. Another take-home message is the alcohol industry uses many tactics for influencing the decisions that governments or institutions trying to make around drinking alcohol and alcohol control. However, there are several cost-effective strategies that have been really shown based on strong evidence to reduce alcohol use. And we've seen Lithuania's pioneering approach to alcohol control as a very strong example for all of us. So basically, reducing alcohol harm starts with us through bold action, strong commitment, and real engagement. So we challenge each of you to take one of today's strategies. Is it the tax policy, a restriction on availability, on marketing, and to think about how to adapt it in your own context and to make it work.
Thanks, Beatrice. And so just a reminder that today's session has been recorded and will be available on the IARC Summer School YouTube channel. And the recording will be shared via email after the session. I'd just like to thank our expert panelists again, and to the organisers of the summer school and the webinar at IARC, and also to my co-chair, Beatrice, and also to our participants. Thanks very much for staying this long. Yeah, let's think about this together and turn the lessons that we've learnt today about alcohol control into action and move closer to a future free of alcohol's harms and free of the alcohol industry's influences. So thanks very much again, and yeah, good luck everyone who's coming to join us for the IOC Summer School and traveling to Lyon. I'll see you soon. Okay, thanks everyone.
Bye.
Bye.